Hi everybody, this is Dr. Peters. I'm going to do the renal pathophysiology wrap-up this week. Instead of meeting online, I am going to do this recording. So I'm going to review obstruction and kidney stones, UTI, glomerular disease, acute kidney injury, chronic kidney disease, nephrotic syndrome, hemolytic uremic syndrome, and incontinence. So when we talk about urinary tract obstruction, it can occur at any time. And what are some of the causes? So while the most common cause are kidney stones, there's also other reasons. You can have a stricture in the ureter. You can have a tumor in the kidney area. Also pregnancy from the pressure and the change in blood flow and urine output can cause an obstruction. Also, if you have your pelvic organs prolapse, I'm talking females, so if you have your uterus that's in this area and your bladder, remember they're only held up by ligaments, not bone. They are attached to the bone, but really held up by ligaments. So most commonly, if you have a pregnancy, multiple pregnancies, these ligaments become weakened, pushes down, as well as pushing on the bladder, and therefore the urethra can obstruct, as well as a neurogenic bladder can cause urinary tract obstruction. I want to focus on renal calculi, though, because those are the most common. There's different types of stones. I wanted to put this slide up because you can see a picture. This is very extreme kidney stones. Now with this type, they have to go in through the side of the flank area and go in and retrieve some of these stones out. They may have to do the lithotripsy to blast them, to break them up and then go retrieve them. There's different ways to go about getting out these kidney stones. Kidney stones also work by gravity. So if you look down here, if you have a kidney stone up in the upper pole of the kidney, most likely it's going to fall down and go down the ureter. Just want to erase this here. But if you have one in the lower pole of the kidney, again, think of gravity. Sometimes it can sit in here and it's not going to easily just jump up and go down the ureter area. There's different sizes. So if it's more than 5 millimeters, they can easily get stuck. There's 3 different places that kidney stones get stuck. Right here in the upper ureteral junction, right here where the artery crosses over with the ureter, and also right here emptying into the bladder. So now let's talk about types of stones. The most common type of kidney stone that you can have is calcium, and actually calcium oxalate. But calcium, we really don't know why this happens. There are some genetics why people can accumulate stones, possibly dehydration or a combination. There's calcium stones, calcium oxalate stones, struvite stones. So when you think of struvite stones, which are made of magnesium, ammonium phosphate, think of them as staghorn calculus. I always think of it as like little, there's no rhyme or reason, and those are very difficult to pass. If you have more alkaline urine and pathogens, those are more susceptible to accumulating the struvite stones. But again, the most common are renal calculi. And as you get into adults 1 and adults 2, we'll learn more about the how to treat kidney stones. I know I mentioned a little bit about the lithotripsy. You can blast them, but more so you'll get into diet and things like that. Right now, we're strictly talking more pathophysiology, and that's the gist of that. So we're going to talk a little bit here about urinary tract infections. So remember, bacteria obviously enters the urinary tract either through the penis or the vaginal urethra. If they have a catheter, it can get in through the catheter. But why I brought up this is because of the biofilm formation. So bacteria sticks to the catheter because it forms this biofilm. And so what this happens is allows antibiotic-resistant bacteria to develop. We see a lot of this in nursing homes. So there's a lot more parameters out for patients not to have catheters in. There are some, though, that it's just reality that they have long-term catheters. Also, people also are chronically colonized with bacteria. So if you're paraplegic, quadriplegic, you have a neurogenic bladder, you have to self-cath, those people have chronic colonization of bacteria. So what does that mean? Every time you do a urine sample, they have bacteria automatically. So you don't treat that unless they start having symptoms such as fever or discomfort, or elderly, we have to watch for confusion. But go back to the pathophysiology. So when the catheter stops flowing, bacteria in the bladder reflux back into the ureters and kidney, which then cause signs and symptoms of infection. So it's really important to make sure that we do good catheter care and have a catheter in as least time as possible. I do want to go back to this slide real quick and just mention that if you have an obstruction in one side, what is going to happen? Things are going to back up, and the opposite kidney is going to get a bulk of the work, bulk of the stuff, the backup, and then the other kidney can become hypertrophied and go into hyperfunction or hyper overload, basically, because things end up backing up. All right, so let's talk about the glomerular damage. What causes that? Well, think about diabetics. So if you have a high blood glucose, high blood sugar, so you have too much sugar running around in your bloodstream, what was going to happen? This glomerular filtration is the pressure is going to increase, and if the pressure increases, it's going to cause damage. Another common cause is hypertension. So I'll talk about hypertension in a couple more slides ahead, but remember with hypertension, you have the renin-aldosterone angiotensin-aldosterone system, the RAAS. But what happens is, to the glomerulus, is the blood vessel walls thicken, and then that changes the glomerulus. So that's when we start having damage, which would be a chronic kidney injury, renal failure, and trickles down from there. Because if you don't have good filtration, then you end up with kidney disease. And this is a good segue into the diabetic kidney disease. As I mentioned, the high blood sugar, the blood flow increases, the filtration pressure increases, the glomerulus thickens. Usually the first sign is microalbuminuria, which is why with diabetics, it is guidelines to get a urine for microalbumin once a year. If it's abnormal, we get it every time they come for their visit, every 3 to 6 months, and we watch it. So what's the treatment? We give them an ACE inhibitor that helps increase flow to the kidneys, because remember, go back to the RAAS system. We want those kidneys, vessels to dilate so that you can have better perfusion of the kidney. If you have microalbuminuria, means you have protein spilling in your urine. That tells me that you may have some damage to the glomeruli. All right, so let's go to acute glomerular. Oh, it's hard to say that word. Acute glomerular nephritis. It's just a tongue twister word for me. But what is it? It's inflammation of the glomeruli. This is acute. So what we were talking about before is more of a chronic kidney damage issue to that glomeruli. This is acute, and this is most commonly caused by strep infection. And what happens when you have the strep infection? Remember, there's an antigen-antibody issue. So the antigen-antibody complexes form, and then they end up depositing in that membrane and causes damage. It causes inflammation and damage, and it's usually caught about a week to 12 days post-strep infection, which is why it's so important to treat strep and not miss strep. So when people come in with sore throats, we do the best we can to screen them, to say, okay, should we test them for strep or not? You don't really want to miss a strep because of the complications of it. Nephrotic syndrome. It's a massive loss of plasma proteins. And what can this be caused by? So this can be caused by inflammation of the glomeruli, as well as other issues such as lupus, which is an autoimmune disease that can affect the kidneys. But this one's basically, you have a decrease of oncotic pressure, and then you have a massive loss of proteins. All right, so now I want to switch over and talk about acute kidney injury. What are some causes of acute kidney injury? Well, sepsis can cause, got to draw in here. Sepsis is one, which ends up causing dehydration. Think of hypovolemic shock or septic shock, as I said in sepsis. So if you don't have fluids filtrating through the kidney, the electrolytes are becoming unbalanced, and your serum creatinine increases. So what does the rifle criteria do? Well, it determines the severity of the acute kidney injury, and as you can see, the rifle stands for risk of renal dysfunction, injury, failure, loss, and end stage. So loss and end stage are basically outcomes of what can happen if you have kidney damage. But if you look over at this table, you can see if there's a specific urine output and creatinine, that will tell you if they're at risk, or if there is actual injury, or if there is actual failure. So for example, if they do have failure of kidney function, increased creatinine times 3. So they've checked 3 serial creatinines, and the GFR, or the glomerular filtration rate, is of 75%, and creatinine is greater than 4. So then that would tell me that they have failure of the kidney. And if this goes on greater than 4 weeks, it becomes a chronic issue, and that's more of a, yes, they have chronic kidney disease. Hemolytic syndrome, in a nutshell, real quick slide, bacteria, which are toxins attached to these glycoprotein receptors in the intestines and glomeruli. And you become anemic, your platelets go down, and you have acute kidney injury. So it's usually in kids from an E. coli infection, and if these kids come in, again, it just takes really good history taking. I don't work with kids, but these would be more for pediatrics. So you would have to definitely do a really good history and use some detective work to narrow this down to, usually these kids would be pretty sick and they would need blood work anyways. All right, chronic kidney disease. So this is probably one of the more common things that you're going to see in clinical settings and as you go out and work as a nurse. It's very common, and we talked about diabetes as being a common cause, and we're watching that microalbumin. We're also watching the GFR, which is the glomerular filtration rate, as well as the creatinine. There's different staging criteria, but the most common way to stage it, according to the American Academy of Nephrologists, American Academy of Family Physicians, and guidelines in general. There's stages. There's 1, 2, 3A, 3B, 4, and 5. So when I get labs on my patients, doesn't matter if they're diabetic. Remember, hypertension is another common cause, as we talked about before, of chronic kidney disease. So I'm always checking their creatinine, and I'm checking the GFR. These people, if they are in stage 3A to 3B, and again, if you want to go to just Google stages of kidney disease, it'll bring you to the guidelines, and it'll give you certain criteria that I believe it's the Nephrologist Association. You can enter like the blood pressure. It's more of a calculator, or you can use an algorithm to determine what stage of kidney disease they are. It actually gives you what treatment that they should be on at a specific time. I send my patients to a nephrologist once it hits 3A. If they're diabetic, if they're still a stage 1 or 2, I'll make sure they're on an ACE inhibitor to increase the filtration. Once they start getting 3A and on, they need to see nephrologists. That's when they do more testing, 24-hour urines, and much more in-depth laboratories, and make sure that they're doing okay on their electrolytes, such as what if my patient has an increased phosphate, magnesium, you have to watch potassium. These are usually elevated, and sodium and calcium are usually decreased. Now, this is textbook. Sometimes you're going to see it different, but if people have kidney disease, you're going to retain potassium, and therefore you're going to need to watch their heart rhythm. They're at very high risk for arrhythmias. So angiotensin II is primarily responsible for chronic kidney disease. Again, go back to the renin angiotensin aldosterone system and make sure you look up as what angiotensin does and what it's responsible for. So if there is kidney damage, the angiotensin II is going to increase, and because the nephrons are becoming damaged, it's not functioning, which is why we put people on an ACE inhibitor, so we can increase that rate. But angiotensin II, the progression of it, nephrons become damaged, therefore the RAAS system becomes malfunction also. And then when we say protein accumulates in the tubules, we see you're spilling not only microalbumin, but macroalbuminuria and protein, which albumin is a precursor of a protein spilling in the urine, and to cause a chronic kidney disease and kidney damage. Once patients go into stage 5 kidney disease, they need dialysis. Many patients, if they're in stage 4, they will go ahead and get them ready for dialysis and put in a fistula, perhaps, or a graft, just depending on what their vessels or their veins look like. All right, so let's move on.